2019 National Resource Center for Patient-Family-Centered Medical Home Education Series, Gaining Ground, the Primary Care Pediatrician's Role in Public Health Systems of Care for Children and Youth with Special Health Care Needs. My name is Christy Moore, and I'm the moderator of this podcast. I'm the Family Liaison Specialist with the Children and Youth Branch in the North Carolina Division of Public Health, where I work with North Carolina's Title V MCH programs with a focus on programs for children and youth with special health care needs. I'm also the parent of an 8-year-old daughter who has special health care needs. This is the second episode in a 3-part educational podcast series brought to you by the National Resource Center for Patient-Family-Centered Medical Home, or NRC, at the American Academy of Pediatrics, or AAP. The NRC is being joined by partners in the co-sponsorship of this educational series, including Bright Futures Natural Center, Healthy Tomorrow's Partnership for Children program, AAP Council on Children with Disabilities, AAP Council on Community Pediatrics, the Association of Maternal and Child Health Programs, and Family Voices. To learn more about the NRC and co-sponsors, relevant websites have been linked in the bio for this podcast. The NRC is a cooperative agreement between the Maternal and Child Health Bureau of the Health Resources and Services Administration and the AAP. The goal of the NRC is to improve the health and well-being of and strengthen the system of services for children and youth with special health care needs and their families by providing technical assistance and supporting implementation of the patient-family-centered medical home model. By the end of this 3-episode podcast series, participants will be able to do the following. Describe the history and purpose of the Maternal and Child Health, or MCH, Services Block Grant, or Title V of the Social Security Act. Discuss the role of primary care pediatricians in state Title V MCH Children and Youth with Special Health Care Needs programs, block grant programs, and partners. Identify opportunities for partnership or collaboration between Title V MCH Children and Youth with Special Health Care Needs programs, families, and primary care pediatricians in advancing the medical home model for care for children and youth with special health care needs. Describe benefits of collaboration between Title V MCH Children and Youth with Special Health Care Needs programs, families, and pediatricians. The focus of this episode is on opportunities for partnership between pediatricians and state Title V MCH Children and Youth with Special Health Care Needs programs from the pediatrician perspective. It will feature a conversation with Dr. Jim Duffy, MD, MPH, a community pediatrician from Ohio who is chair of the Medical Advisory Council for the Title V program for children with disabilities at the Ohio Department of Health. Dr. Duffy is an AAP member and the chairperson of the AAP Council on Community Pediatrics and a member of the AAP Council on Children with Disabilities. Dr. Kathy White will be joining Dr. Duffy. Dr. White is a pediatrician in Butte, Montana, an AAP member and chapter president of the Montana chapter of the AAP. Towards the end of the episode, we will share a list of resources discussed during the conversations, as well as additional resources that can support participants in medical home implementation. I would now like to begin the episode by asking our speakers to introduce themselves and provide an overview of their involvement with Title V MCH Children and Youth with Special Health Care Needs programs. There's also a great deal of variation among Title V MCH Children and Youth with Special Health Care Needs programs. Can you also provide a high-level overview of these programs in your state? Dr. Duffy, would you like to begin?
Thank you, Christy. As mentioned, my name is Jim Duffy. I'm the chair of the Medical Advisory Council for the program in Ohio that administers the Title V grant. It's referred to as CMH, or Children with Medical Handicaps. Every state has a unique Title V program, and Ohio has a very unique. There's nothing like it. It functions as a payer of last resort. It's not an insurance program, but it fills in between Medicaid and private insurance and self-pay gaps, fills in those gaps, so that if a family has a problem paying for a service, then the Title V program steps in, our CMH program. The purposes include linking a network of qualified clinicians to families, and as I mentioned, being the final payer. The funding comes from federal, state, and local sources, The programs are divided into three. There's a diagnostic program that's available to all children, a treatment program that's based on diagnosis and income eligibility. And there's also service coordination that takes place coordinated with local health departments and children's hospitals. The MAC, or the Medical Advisory Council, is in place to advise the Director of Health on the administration of the program, and in particular standards of care and medically eligible conditions. In addition, we review potential clinicians for their qualifications to make sure that families and children receive the highest level of care possible and see the most appropriate person to provide that care.
Thank you, Dr. Duffy. Dr. White?
Hi, thanks, Jim. I'm Kathy White. I'm a pediatrician and president of the Montana chapter, as I said, of the American Academy of Pediatrics. And our Montana Title V Maternal and Child Health Block Grant is administered by our Family Community Health Bureau, the Public Health and Safety Division, one of 12 divisions in the Montana Department of Public Health and Human Services. Public health in Montana is decentralized. There are 56 local county boards of health to oversee each county public health department. It is important to know that Montana is vast in size. There's 145,546 square miles. It's the fourth largest state, but we're a small population of 1.5 million. We have diverse geographical landscape, mountains in the west and semi-arid plains in the east, and a racial composition shared by few states, with American Indians being the principal minority, makes it unique. More than 50% of Montanans live in rural or frontier areas distinguished by limited access to health care at all, and in fact, it creates an exceptional obligation for assuring access to public health care. Therefore, we're quite spread out and have to be creative with our Title V funded services. We have about 112 pediatricians. We spend about $1,600,000 on Title V children with special health care needs per fiscal year. We are working on the national performance measure of medical home and on the state performance measure of family support and health education for children with special health care needs. I will later explain in more depth these programs.
Thank you, Dr. White. Title V programs and services do vary greatly from state to state. In the first episode of this podcast series, faculty discussed the formation and function of the MCH Title V Block Grant and its role in supporting systems of services for children and youth with special health care needs. In this episode, we would like to highlight real-life opportunities for partnership between primary care pediatricians and Title V MCH Children and Youth with Special Health Care Needs programs. From your perspective as a pediatrician, can you discuss how you have successfully partnered with Title V MCH Children and Youth with Special Health Care Needs programs, and any tools, resources, or strategies that made this possible? Dr. Duffy, would you like to begin?
Thank you again, Christy. The collaboration between primary care pediatricians and other community-based clinicians and the Title V program is really directed towards improving care coordination in the major sense, in the broad sense, for children with special health care needs and their families. I'd like to concentrate my comments on children with medical complexity, which is really the group of children that we cover most directly in our Title V program. And those children have 2 or 3 active chronic conditions and are high utilizers and have a significant functional disability. Service coordination or care coordination is one of the main ways that we can help those families, not only to link to other services, but also to provide support during transitions of care. And what I mean by that is transitions from, for instance, hospital to home, as infants are discharged from hospital after a long neonatal stay, for instance. and in particular, children with technical requirements or they're technology-dependent children. And the other transition that's really important is the transition to adult care, finding adult caretakers and adult clinicians to care for children with medical complexity and youth with medical complexity. One of the most important services that local pediatricians can access really is a home visiting program through Title V, and in particular in this case I'm speaking of a home visitor who is also a dietitian. Children with special health care needs and their families have a higher quality of life when enteral feeding is supported, and when their sense of agency and their sense of independence is supported in feeding when families are able to feed their children. In Ohio, all children are eligible for unlimited home visits with a dietitian, which is an excellent resource for pediatricians to access. Beyond the Title V programs, I'd like to mention a couple of things. One is the benefits of shared decision making, and particularly when a local pediatrician or a medical home knows the family and actually becomes part of the family over time. Those clinicians can meet with the families and provide information and share and even use shared decision-making tools to support the decisions that are maybe something like placing a G-tube for a child who's not growing properly. Families benefit tremendously from that information and that relationship that's developed with the primary care clinician. It improves engagement and improves timeliness of that decision making. The other two things that I want to mention before moving on, one is the necessity for team-based care. That's something that local pediatricians have to learn, is how to become a leader of an interagency or interdisciplinary treatment team. That's a new skill set for most community pediatricians. Also is the need to address family wellness in a broad sense. It brings up the benefits of integrated primary care, collaboration, either co-location or facilitated referral for family members, siblings, parents, caretakers, even foster parents in terms of medical foster care, to a mental health or a provider who's able to help the family adjust over time to the stresses, high stresses of caring for children with medical complexity.
Thank you, Dr. Duffy. Dr. White, how have you successfully partnered with your state's Title V MCH Children and Youth with Special Health Care Needs program?
Well, we have similar issues as Ohio, as small as we are. I began working with children with special health care needs 12 years ago through the AAP's Mountain States and Regional Genetics Collaborative. I thought this would be brief, but hearing the stories what parents and children with special health care needs have to do on a daily basis just to exist was compelling to me, and thus began a long relationship. It was there I met Brad Thompson from Texas. He's a counselor with a daughter, Hallie, with special health care needs. He was working in his daughter's doctor's office with parents of children with special health care needs to help them to navigate the system. Every time I met him, I asked him to bring the Hallie Project to Montana. Eventually did, and that is how the Parent Partner Program was formed. The Children's Special Health Care Services took this on as part of Title V federal initiative for medical home for children with special health care needs and as part of the state performance measure for family support and health education. Montana Parent Partners Program employs personally experienced and professionally trained parents of children with special health care needs who work in 6 sites across our state, and they receive referrals of families in need of additional support to navigate the complex systems. Parent Partners averages about 35 minutes per visit, and this frees up the time for the providers and allows them to better work within their scope of care. About 8 years ago, I was asked to join the Butte Community Council. This council is made up of principals, teachers, librarians, Head Start personnel, the chief of police, daycare providers, AmeriCorps personnel, and multiple other people representing social organizations throughout our community. We meet monthly, and the Butte Community Council works on early childhood health and well-being. We've developed 3 home visiting programs: Nurse-Family Partnership, Parents as Teachers, and Safe Care. Other cities in Montana have now adopted these programs, and we also have the Family Spirits program on the reservations. These programs start in utero and extend to 5 years of age and are very helpful for families with children with special health care needs. Through them, they can learn about, cope, and better understand their children's needs and what they can do for them at home as well as in the community. About 5 years ago, I received a catch grant from the National AAP for planning and then another for implementation. These catch grants were to develop mental health services in our community, and they aimed at 3 specific areas. One, to develop a tool that showed our local resources for counseling and mental health providers. At onset, we thought we had a shortage in the community, but as we formulated this tool, we found that was not the case. We disseminated this information to schools, local counselors, clinics, and clergy. We then worked to utilize all counselors and providers that we had in the community. This chart was so popular, it eventually went online. And then through the AAP, this format was adopted in other cities in Montana. The Continue Your Story project for teen suicide prevention was our main catch grant focus. This was posters, billboards, bus benches, and community signage that had national and local telephone numbers and national text numbers to contact for resources if you were feeling suicidal or knew somebody who was. This eventually spread to other cities in Montana through the AAP. After starting that part of the project, we had contacted the national text line and were told that Montana had one of the highest utilization rates in the country. Third part of this was due to having many young physicians in our area who wanted more training with children and youth with mental health issues. We arranged for psychiatrists to precept any physicians who wanted training for 1 hour once a week prior to clinic hours. This has now worked into a once a week, 1 hour, noon telemedicine echo project and phone consultation with the child psychiatrist in our state if needed as well. A fourth part was eventually developed that was not part of the original catch grant, and this was that we joined the NOBLE HIPAA-compliant psychiatric referral system where providers can track referrals and reply to the senders. It used to take some patients 6 to 12 months to show up for their referrals, and often they were in crisis. Now we can see these referrals early, and if patients are not keeping appointments, we can have case managers, parent partners, or the referral source track them down. We have much better outcomes with this. Montana is top in the nation for teen suicide. This is also an issue for our children and youth with special health care needs who are helped through this referral system. One last outcome that came from the American Academy of Pediatrics Catch Grant was that through community forums held in Butte, parents of children with special health care needs told us they needed support. 2 dedicated mothers took on this task with the local Circle of Parents chapter. They have monthly meetings with free dinners provided, free childcare, and stimulating conversation. They have speakers on IEPs, support animals, and other pertinent topics. These meetings are curious, informative, and never mean-spirited. Because of them, we've been able to have friendlier, better interactions with our local school system. Parents feel less isolated, and there's dissemination of parents' best practices. As at these meetings, parents help each other get their kids involved in programs early, like Special Olympics, transition programs, enrolling in adult developmental disability services, counseling, and other referrals. We're now embarking on a circle of grandparents to help that much-needed population. Other Title V programs that I have been involved with over the past few years include, 1, the Montana Medical Home Portal. Children's Special Health Services partnered with the University of Utah, the University of Montana Rural Institute, and PLUC. That stands for Parents Let's Unite for Kids. It's a family-to-family agency in Billings, Montana, and part of Family Voices. The portal is a one-stop shop for families, providers, and agencies. There is diagnostic information, treatment options, referral to state and local resources, including vetted, up-to-date clinical information about accessing care, and a statewide services directory. This directory was originally started by PLUC. The University of Montana Rural Institute reviewed it, updated the 800 existing resources, and added 300 new resources, and focused primarily on pediatric health care providers. Next was the Children with Special Health Services contracted the University of Montana Rural Institute to provide transition education and support to individuals, providers, and families. They developed a transition guide with webinars on self-advocacy, speaking up for you and what you need, inclusion, we are all benefit, independent living skills, and resources for transition-age youth. Third thing was we are using social determinants of health with parent partners and case managers to help parents become aware of community resources.
Some great examples of meaningful partnerships. Thank you both. You both discussed very diverse examples of how you were involved with Title V MCH Children and Youth with Special Health Care Needs programs in your state. The systems that serve children and youth with special health care needs are complex and multidisciplinary. We'd now like to hear about the benefits of these partnerships or specific improvements that you've seen in serving children and youth with special health care needs because of these collaborations, such as successful implementation of programs increasing the percentage of children who are receiving care within the medical home model. Dr. White, would you like to begin?
Yes, thank you, Christy. These programs have allowed me to have more time to practice within my scope of care. They also have helped me to better understand my patients. Parents tell parent partners information they do not tell providers. We heard that patients were not keeping referrals because they did not have money for transportation or lodging. From that, we hung up signs in our clinic that said that transportation and lodging were covered by Medicaid and to please ask our case manager if they needed assistance. We also hung up signs about Angel Flight for children with special health care needs and their families to be able to fly to distant appointments for free. I had a mother who would tell me she was going to take her children to many referrals due to his significant health care needs, but over the course of a couple of years, she never kept any appointments. There was a disconnect. I had a parent partner talk with her, and over the course of 2 hours, it was revealed that the mother had a closed head injury and had short-term memory loss. She would leave our clinic with every intention of keeping these appointments, but then could not remember them. Our parent partner was able to make her a paper calendar with all the appointment dates, and then she would call the family 3 days, 2 days, 1 day before, and the day of the appointment. We were able, he was able to keep all his referral visits. His health improved substantially, and it was a win-win situation for us as well as the patient and his mother. That saved me innumerable hours and the system a lot of money for kept appointments and no more no-shows. What we have found through these programs is that parents want what's best for their kids and sometimes aren't sure how to access the system or to know what's available or have too many conflicting issues at home to be able to do what's best. Through the Montana AAP, we've tried to remind young providers that these things are available through our Montana system and to inform their parents so that they also will have better outcomes. Thank you.
Thank you, Dr. White. Dr. Duffy, what benefits of partnership with your state's Title V MCH Children and Youth with Special Health Care Needs program have you seen?
Thank you, Christy, and thank you, Dr. White. Those were great examples of a specific help to specific families. I'd like to sort of summarize some opportunities for collaboration that I've learned over the last few years. And I mentioned a lot about coordinating health services and linking services to community activities and resources. Our Title V service coordinators, actually they're both hospital-based and community-based in health departments, make home visits and link families to local services. For instance, skilled nursing resources or DME services, durable medical equipment services. But from the pediatric standpoint, and both of those, tremendously, as Dr. White has pointed out, tremendously support the local pediatrician. But I'd also say that there are sort of bigger population health benefits of collaboration. One is sharing information for improved population health management, just knowing where kids are, helping local pediatricians develop a registry of children with chronic conditions so that they can follow the children more effectively and identify through their IT services gaps of care, for instance, or even something as simple as vaccines, and important as vaccines for children with special health care needs. Sharing information, implementing training in population health on particular topics relevant to children with medical complexity, including family wellness, including family dynamics, and attention to secondary traumatic stress and sibling concerns, for instance. On a bigger level, pediatricians can serve as an advisor to the program, such as the Medical Advisory Council that I chair. It's a very important service to identify to folks in administration who may not be comfortable or understand, may not have the knowledge base to understand the benefits of a certain treatment or a certain special diet, special nutrition, to identify those situations for those who are the payers to say this is important to pay for and this is why it's important, it's life-saving. So participating in budget development is really an important activity. And in our model of care, the Parent Advisory Council is actually a subcommittee of the Medical Advisory Council. So we work very closely with a very activist group of parents who are well known to the General Assembly in Columbus. And during the budget season, we're often in Columbus talking with legislators and talking with administrators about how to adequately fund on a statewide basis children with medical complexity and children with special health care needs in general. The last recommendation, the last opportunity for collaboration, I think is really important. I started with, and that is identifying or developing a registry of children with special health care needs in your practice and collaborating with local agencies and the local health department and the Title V services to develop disaster and emergency response strategies for children with special health care needs. And that can mean children on the autism spectrum, for instance, who would respond very differently to an emergency, or something that's very concrete as making sure that electricity is restored as quickly as possible in the midst of a power outage to families that have technology dependence, particularly ventilators or G2 pumps, for instance. These are many different ways that a local pediatrician can collaborate with a local health department, with public health, and in particular with the Title V program in their community.
Thank you, Dr. Duffy, for those great examples, and thank you both for sharing your wonderful examples of the benefits of partnership. Dr. White, if you had to share one lesson learned with the audience about systems building efforts, what would it be?
Well, I try to tell all pediatricians in our state to steal shamelessly from programs that are working. Don't be afraid to ask for money or programs. Sometimes a person you least suspect will have the answers for you. Don't undervalue what you know. Be ready to share your expertise with your community. Value what everyone brings to the table, parents, patients, community personnel, and staff. And sometimes they will have answers you're looking for, or the ability to look at issues in ways we weren't trained to do. Lastly, remember people from the state agencies will welcome the collaboration with you, so reach out to them. And I'm so glad Jim brought up about the disaster response, because in these rural areas, it's so important in helping our families. Thank you all for your time.
Thank you, Dr. White. Dr. Duffy?
I think that was a great response, and I have little to add to that except just to amplify the benefits of collaborating not only with community resources but also with parents and families. Parents and families, are struggling as the population of children with special health care needs expands, in particular children with medical complexity. Again, those that we care for in our Title V program. That population is increasing. We're seeing children discharged from the NICUs and the PICUs at a greater rate, and they live long lives, even children with congenital disorders like cystic fibrosis. When I trained 40 years ago, many of those children had very short lives. Now they have long lives. And so we have a different problem. We have a different group of kids that are moving from teenage years into adulthood with chronic conditions, or children who have been treated for cancer, for instance, or for leukemia as young children and have survived that, but have long-term effects, systemic effects of chemotherapy. So we have this group of people that are living longer and living with chronic conditions, and that creates a very different level of stress for families and for those children. And I think the challenge to pediatricians who are caring for children with medical complexity within communities is to understand how that population is changing, how we can follow that population, support that population, and think broadly about family wellness rather than think narrowly about the system that's involved in whatever disability that the child started with.
Absolutely. Thank you so much. Dr. Duffy, what would you recommend a listener of this podcast do within the next month to build or enhance partnerships with the Title V MCH Children and Youth with Special Healthcare Needs programs?
Right. I think the most important thing is to, just very concretely, practically speaking, is to learn about local Title V resources and create a resource list that can be accessed easily by somebody in the practice. It may not be necessarily a professional. It could be somebody from the community who's working in the practice that just has that sense of ability to work with families. Keeping a resource list of providers of alternative or augmentative therapies, habilitative therapies, DME, durable medical equipment, skilled nursing. Also food resources, nutritional resources, home visitors. Keeping a resource list for children with special health care needs that starts with the local Title V services that are available in your state. Learn about those, keep a resource list, assign somebody in the practice, not necessarily a health professional, to take care of that list and be available to families as you identify families that are in particular need of those services, so that linking process can start at the medical home and move out into the community.
Great. Thank you, Dr. Duffy. Dr. White?
I really think he brought up pretty much everything I would say, and I would echo that, other than in your practices, I would encourage people to start looking at social determinants of health as part of the medical home anyway. What we're finding is so many of these families have housing issues, food insecurity issues, and if we're not addressing those problems first and foremost, what I'm finding is we're not able to work with these families or fix or help them with the health problems that they have. So I just encourage you to look at those things as well. Thank you.
Absolutely. Thank you so much, Dr. White. Thank you both, Dr. Duffy and Dr. White, for sharing your experiences with us today. Thank you, too, for sharing tools and resources available to the public to learn more about this topic. We greatly appreciate your time and insights. All the resources discussed during this episode will also be included as a PDF and archived on the National Resource Center website. If you would like to be connected with Dr. Duffy or Dr. White, or have any technical assistance needs, National Resource Center staff are available to facilitate introductions and provide tools and resources. On the National Resource Center website, below this recording, you will see a link to a short evaluation survey for this podcast series. We would greatly appreciate your feedback. This concludes the second episode of Gaining Ground, the primary care pediatrician's role in public health systems of care for children and youth with special health care needs. Thank you so much for your participation.